Okay, so today let's speak about headaches. So first of all, we know that there are three types of headaches, only headaches. I'm talking about the main type of headaches, that is tension, cluster, and migraine. There are also other things that cause headaches, other causes of headaches. So all of these we can discuss later at the end of the topic. So now, tension headaches, cluster headaches, and migraine headaches. So these are the three main types of headaches that are seen usually in the normal population, in the general population. So I've made a table. Some kind of headaches is most commonly seen in females. Tension and migraine, both are most commonly seen in females, whereas cluster headaches is most commonly seen in men. Yeah, this is very important. This is a very important differentiating factor. Female, male, and female. And uni or bi. Tension headaches is usually bilateral. It presents like a band, like it surrounds it. You can see here. It surrounds the whole head like a band. So it will be bilateral everywhere, honestly. And then cluster and migraine is usually unilateral. You can see here, cluster is especially periorbital. This is periorbital. Periorbital in the sense it is around the eye, around the orbits. Therefore, it is usually periorbital, whereas migraine headaches is also unilateral, but it surrounds the whole, it is usually pulsating, and it surrounds the whole head, one side of the head. Therefore, it is unilateral. Therefore, bilateral, band-like, or fronto-occipital, because it comes both on the frontal side and the occipital side, like around, like this. And then periorbital pain is seen in cluster headaches, and pulsating unilateral pain is seen in the migraine headaches. Cluster headaches also present with rhinorrhea and lacrimation. It'll be like you've got a cold, a severe cold, and a severe headache. That is going to be the presentation of cluster headaches. This is very important. The patient, the male patient, most commonly seen in males, the male patient is usually going to present with a severe headache, which is especially severe around the eyes, around the orbits, and he's got rhinorrhea and lacrimation. That is nothing but rhinorrhea, nose and nasal discharges, and lacrimation is nothing but tearing of eyes. And migraine is usually going to present with aura. So what is aura? Aura is nothing but, it is a feeling. It is like a feeling. You know before you get the actual headache that yes, you're going to get the headache now. That is what aura means. So it is usually, it could be it is like a signal. Yeah, it is like a signal. One of the main auras in female is menses. Either premenstrual, before menstruation, or after menstruation. The female knows that with her menstrual cycle, she's going to get a migraine headache. Similarly, there are so many more photophobias or phonophobias. Photo means light. Headache which gets severe with light or sound, phonophobia. And then aura means, and also it is going to present with pound findings. So positive aura, positive pound. Pound is nothing but, it is just a simple mnemonic which everybody uses. So P for pulsating, O for 1 day. 1 day in the sense it is usually around 24 hours. The headache persists for around 24 hours. But if it goes above 72 hours, that is going to be called as status migrainicus. Above 72 hours, but it is usually only for 1 day. It is not only, to be honest, but anyway, it is going to be for 24 hours. And then unilateral, as we have seen here, and it is also going to present with nausea. This is also one of the auras. Nausea and vomiting can also be one of the auras. The patient can get nausea and vomiting, and then that is like a signal. So yeah, now I'm going to get the migraine now. So that is also one of the auras. And then disabling in nature. Disabling in the sense the patient won't be able to function at all with this kind of pain. It is like, you're going to request everybody, please don't switch on the light, please don't make any noise, please. It's going to be that way. It's going to be very severe and very disabling in nature. So the treatment, and anyway, in any kind of headaches, before you make the proper diagnosis, you are going to rule out stroke. Rule out stroke every time. Whenever a patient presents with headache, in case fever is absent, you have to rule out stroke, because if there is fever, you can think about meningitis and other infective diseases. And the treatment is, for tension headaches, you can just give them any painkiller, NSAIDs or any acetaminophen or any kind of painkiller. And also for migraine, you go with NSAIDs first if it is mild or near moderate, and if it is severe, for cluster and for severe migraines, you're going to give triptans. And the most commonly used triptans are sumatriptans. Triptans are nothing but they are vasoconstrictors. So you have to constrict the blood vessels in the brain. I'll tell you about it later. Therefore, vasoconstrictors most commonly used as sumatriptans. Here also you give sumatriptan for migraine, for severe migraine. And then the etiology of migraine. So it is usually due to cranial 5 irritation or any kind of meningeal irritations. Like the dura mater, you can see here. Any kind of meningeal irritation or cranial nerve 5, that is the trigeminal nerve irritation, is going to affect the nociceptors, which are in turn going to cause pain. So why does this happen? Why do the cranial nerve 5 and the meninges, either of them, why do they get irritated? Because our brain releases vasoactive peptides. Vasoactive peptides are, they can either vasoconstrict the blood vessels in our brain, they can either vasodilate, they can do anything, they can cause any kind of vascular changes. So when vasoactive peptides are released, they cause different kinds of vascular changes, leading to intracranial vasoconstriction. So you can think this is the brain. This is the brain. These are the meninges. So whenever there is intracranial vasoconstriction, the usual blood vessel is constricted. So to compensate that, the extracranial blood vessels are going to be dilated. So you can see extracranial vasodilation whenever there is intracranial vasoconstriction to compensate for each other. Therefore, when there is extracranial vasodilation, obviously the dura mater is going to be stretched. It is going to try to move outside. Therefore, the stretch is going to cause the irritation. Either cranial 5 is going to get irritated, or the meninges, that is nothing but the dura mater, is going to get irritated, which, as I told, in turn disrupts the nociceptors, causing pain. So these vasoactive peptides, one such vasoactive peptide is calcitonin gene-related peptide. Another one is substance P, which causes pain, P for pain. And another one is excitatory neurotransmitters like glutamate. These also do the same pathogenesis, causing migraine. All of this happens why? Because of the extracranial vasodilation, which leads to stretching of dura mater. So to prevent this vasodilation, we give them vasoconstrictors like sumatriptans. So now let's talk about the different kinds of migraines. So the two migraines that we need to know for FMG are ophthalmoplegic migraine and familial hemiplegic migraine. So it is in the name itself, ophthalmoplegic migraine. Ophthalmo, it means the eye, the symptoms of eye. Therefore, we are going to get cranial nerve 3 palsy. Cranial nerve 3 is nothing but oculomotor nerve. Therefore, we are going to have many symptoms like squint eye, diplopia, ptosis, and all such symptoms. We won't be able to see medially, we won't be able to see up or down depending on the muscle involved. Therefore, cranial nerve 3 palsy, and we are going to have the migraine symptoms. That is nothing but aura and pound. The pound symptoms is nothing but, as we've discussed, P for pulsatile, O for 1 day, that is for 24 hours, U for unilateral, N for nausea, vomiting, and D for disabling. And then familial hemiplegic migraine. That also, again, it is in the name itself. It is hemiplegic. Therefore, we are going to have contralateral hemiplegia. Contralateral in the sense, the headache, if it is on the right side, that is, if it is right-sided headache, then we are going to have left-sided hemiplegia. And then again, aura and pound. Familial. Therefore, the inheritance. This is an inheritant. This is a heritable disease. Due to a defect in the calcium channel. There are 2 more diseases that occur due to defects in calcium channels, that is hypokalemic periodic paralysis and Lambert Iotan syndrome. So we can remember it like this: calci, yum. Whenever something is yum, we go and eat it. Therefore, Lambert Iotan, and calci, cal-c. So kalemic, hypokalemic, calci. Therefore, hypokalemic periodic paralysis and Lambert Iotan syndrome. Hypokalemic periodic paralysis is nothing but we get periodic in the sense sometimes we get paralysis because of hypokalemia. What happens is basically there's a defect in the calcium channels. Therefore, to compensate for the calcium, the potassium channels also start showing some defects. Therefore, I mean, they try to overact. I mean, they try to overfunction, which will eventually lead to hypokalemia. And hypokalemia always results in muscle paralysis. Therefore, muscle weakness, therefore paralysis, periodic paralysis. And in Lambert-Iotan syndrome, because of the calcium channel defect, there is going to be similar presentation like myasthenia gravis. Let's talk about these syndromes later. And now the other causes of headache. Always rule out stroke, like I told you before. Always rule out stroke. So how are you going to rule out stroke? Non-contrast head CT. Non-contrast head CT. That is going to be your first investigation of choice. And then the main things you need to rule out are subarytenoid hemorrhage. If somebody presents with worst headache of life, if they say it is their worst headache of their life, or if it is called thunderclap headache, then you need to first and always first think about subarytenoid hemorrhage. And there can also be infections, other infections like sinusitis or rhinosinusitis. Like this, you're going to your frontal sinuses, and here these are the maxillary sinuses. So your frontal and maxillary sinuses are going to be affected. So you're going to have lacrimation symptoms, rhinorrhea kind of symptoms, and whenever you press like this here on both the sides, you're going to get pain here. This is frontal sinuses, these are the maxillary sinuses. So whenever you press there, you're going to elicit pain. And meningitis again. Meningitis is nothing but, we know, it is a inflammation in the meninges. So here you're going to have fever. If there is no fever, you can directly rule out meningitis. But if there is fever, you need to think about meningitis. And go for CBC and then lumbar puncture if necessary. The third one is giant cell arthritis. It is a vasculitis kind of syndrome. Vasculitis is nothing but inflammation of the blood vessels. Here the inflamed blood vessel is going to be superficial temporal artery. So the damage is going to be in the superficial temporal artery, which will eventually lead to a damage in the ophthalmic artery. Ophthalmic artery, since it is eye, one of the main symptoms is going to be visual issues. You're going to have jaw claudication because giant cell arthritis, superficial temporal artery. It is also going to, it is basically going to affect the temporomandibular joint. TMG. Therefore, here see, TMG headache. This is going to be your temporal regions. So your temporal regions are going to be affected. Therefore, TMG. Therefore, mandibular joint is also affected. So you're going to have jaw claudications and you're going to have temporal headache, like I told you here. Temporal in the sense near the ear or above the ear, or even behind the ear, in fact. And then you're going to have visual issues because the ophthalmic artery is involved. So whenever a patient above 50-year-old, especially females, but also seen in males, more commonly seen in females though. So if a female above 50-year-old comes to you with these kind of symptoms, jaw claudication, temporal headaches and visual issues may or may not be present. If it is still in the early stages, you won't be having any visual issues, but these symptoms will be there. So if a patient above 50 years comes to you with these patients, you first go for a ECR, and then if it is above 100, you're going to directly give her steroids, because the sooner you give steroids, the more chance you have to prevent the damage to the ophthalmic artery, because any damage to the ophthalmic artery may lead to permanent blindness. Therefore, to prevent the permanent blindness in the patient, you need to give her steroids as soon as possible. And then after you give her steroids, go for a biopsy, temporal artery biopsy, in which you're going to see giant cells. That's it. So this is giant cell arthritis. So these are the other causes of headaches. So here's a few points that we need to know for FMG, that is given for FMG. So as we know about the Pound findings, the diagnostic criteria for migraine is going to be 4 out of the 5 Pound findings. I mean, there are 1, 2, 3, 4 and 5, right? So if 4 out of 5 are positive, or if there are more than 5 such episodes, such migraine headaches, such severe headaches in a year, that is the diagnostic criteria of migraine. Therefore, the diagnostic criteria of migraine headaches is 4 out of 5 of the Pound findings, or 5 migraine episodes per year. And triptans, some information about triptans is the fastest acting triptan is rizatriptan, and the longest acting triptan, that is obviously with more half-life, is going to be frovatriptan. So just a small mnemonic: rise fast, therefore rise fast, and rivers are long because there are long rivers. So frovatriptan, rivers are long, and always use IM, intramuscular prochlorperazine. Oh my god. Okay, that is an antipsychotic. It is a typical antipsychotic. That is the first generation antipsychotics that is usually used to treat schizophrenia. Not anymore though. They used to be used for schizophrenia. Now they can be used for status migrainicus. That is, if the migraine persists for more than 72 hours, as we've discussed earlier, that is called status migrainicus. And then we use typical antipsychotics like this intramuscularly. Because yeah, that's it.